To order, this is a meeting of the Health Subcommittee of Appropriations. In light of recent developments with the budget process, Chairman Harbin has suggested that we go back through 07 and 08. I think, as everybody knows, of course, we have already reported out our recommendations and so forth and been dealt with on 07, but we are not exactly sure where the posture of that is and where that's going to wind up, so we just want to kind of actually go back through the department's requests on 07 and 08, and members may be looking through a little bit of a different lens, and members of the committee, as we do, any questions that you may have, feel free to start. Carrie, are you going to present on behalf of the department?
Yes, sir.
If you would begin, please, ma'am. Carrie, if you would start with 07 and then move into 08, or if you're going to blend them, however you want to do it, frankly.
Okay. Thank you, Mr. Chairman, members of the committee. Good afternoon. Nice to see you again. I prepared just a very brief kind of a highlight thing, but it sounds like we might need to go in a little more detail through each different item. So, Mr. Chairman, I'll look to you. The handout that you're getting from Margie is really just, again, very high level. Just as a reminder, here's kind of the snapshot of 07, and then again, here's the snapshot of 08, and what were the real, sort of the key elements. But if you'd like to go kind of line by line, we can do that.
I'll tell you, why don't we go through what you have here first, and let's see where we get to.
Okay, very good. All right, then starting with amended fiscal year 2007, the main highlights are, of course, probably the biggest item is about $167 million. All of these figures are in state funds. That $167 million is to replace the loss of prior year surplus, that we've enjoyed in both fiscal year 06 and fiscal year 07. Those dollars will no longer be available to us in 08, and the governor's recommendation basically pre-funds that $166 million in 07 for use in 08. You can find that on page 4 of the tracking document. The next item is another pre-funding, $69.1 million to pre-fund part of the fiscal year 2008 Medicaid growth number. State funds, that's a total of $128 million, and 69 of it is being recommended to be funded in 07, with the rest of it being recommended in 08. You can find that item on page 4, item 17.0.2. There are several different items related to agency administrative support. Most of them are related to transfers out of the Medicaid program and one transfer out of the state health benefit program to the department's administrative budget in order to fund a variety of new FTEs that the department has requested for things like contract management support, legal services support for appeals, and eligibility determination positions, and 2 positions to do auditing of the state health benefit plan revenue that's coming in from our payroll locations. So those are really sprinkled throughout the budget. As far as new dollars, it's a little under $150,000 in state funds. Again, most of those positions are being covered by transfers from other programmatic areas within the budget. The next major item is really an accounting item, and that is to reflect what we believe will be the total amount of CMO quality assessment fees that will be collected in fiscal year 2007. All of this would be put into the Peach Care for Kids program as a state matching fund source for any available federal funds. Obviously, those are dwindling by the day, but nonetheless, we do need the state share of dollars. This contributes $22.6 million towards that. And again, those are CMO quality assessment fees that we've been collecting. We just need to make sure that we are reflecting the total amount that we expect to earn and that we are reflecting it in the correct program. We also have about a $10 million recommendation for disproportionate share hospital funding. This funding is specific to hospitals who are considered private hospitals who are eligible for DSH. You can find that on page 5, item 17.4.3. And then finally, the last major item of the 07 budget is $10.8 million in additional nursing home provider fee revenue. Basically, the budget is reflecting the receipt of those additional fees and then the use of them in a provider rate increase for nursing homes in the Medicaid program. And you can find that item on page 5, 17.6.1. So those are really the very high-level sort of key elements of the governor's 07 recommendation. You can take questions before we move on.
Yes, Carrie, just one thing for clarification. There's been some question about that. The $10 million for the DSH funds for private hospitals is being put in, it's being recommended to be put in the supplemental. But that's not on top of what's already there. Is it not true that this money has been traditionally put in for the year at supplemental time?
Well, we only have 1 year of precedent to look to, and that is in fiscal year 2006. The General Assembly appropriated $14 million in state funds in the 06 amended budget. I think the idea of why there's this amount in 07 and you don't see it in the 08 budget is that it's just kind of a one-time agreement, sort of pending some discussions with the hospital industry about finding other fund sources to fund this particular expense item in future years.
But again, my point of clarification is that this recommendation from the department is not on top of other monies that's already in the 07. It is what, if it's whatever's approved will be the one-time funding in the 07. Is that correct?
That's correct. There's nothing in the base today.
Thank you.
Shall I proceed with 08 or?
Yes, ma'am. Be fine.
Well, before I do that, let me just wrap up sort of the numbers side of the 07 budget on the third slide in the handout. And that is just the summary. We're showing a 12% increase in state funds. Obviously, this is because of the pre-funding that's being put in the 07 budget for 08. You have, again, the $166 million for the prior year surplus loss, as well as $69 million for pre-funding the 08 Medicaid growth. And if not for those dollars, the growth in the Medicaid budget would definitely be single-digit and very low. You can see the total impact on the department, $273 million in new state funds. It gets our state fund budget up to about $2.6 billion after considering the governor's recommendations. All right, the 08 highlights. I'm sorry.
Hold on just a second. Who is 26? Representative Gardner has a question.
I'm sorry to be late, Mr. Chairman. I wanted to make sure that the amount of money we allocated to fill the gap, I wondered where that calculation came from. Is that based on the way Medicaid currently, or where the way Peach Care currently is administered?
Well, if you're referring to the House recommendation that included $73 million, it basically gives us authority to move up to $73 million to deal with the federal fund deficit. And then there was an additional $8.2 million in state funds actually moved to Peach Care from Medicaid. Those numbers are reflective of what we believe is the most recent enrollment number. Mm-hmm. For March, that number currently is 306,000 children. So making an assumption that we would have that level through the rest of June, and considering the average capitation payments that we pay to the CMOs, given that the majority of these children will be in a CMO, as well as considering the premiums that we collect from the families, considering fee-for-service costs while the children are waiting to be assigned to a CMO. In other words, considering everything, that $73 million in federal and the additional $8.2 in state is the amount that we believe we need based on the most recent enrollment information that we have available. I think, as you know, that the governor's budget at this did not have that in there. It is only since the House has done their version that you actually you see the way that the outcome of the discussions about how to handle the deficits.
So it's based on the growth and using the current guidelines for peach care.
Correct. There are no assumptions about reductions in scope, no reductions in payments to providers, pretty much a status quo program based on the very latest enrollment that we have. I know everyone is aware the program was frozen as of March 11th. And so one of the reasons that the enrollment number is not as firm is because people had till March 11th to get their applications in. If they were postmarked by the 11th, we would still accept that as being on time. Obviously, the vendor that does our eligibility determination has to evaluate all of those applications, and mail is still trickling in, so we should have a final number pretty shortly.
Thank you, Mr. Chair.
Representative Gardner and Hughley and Chairman O'Neill, just to kind of let you know for sure where we are and what we're about today is that in light of recent internal developments, we are, at the request of the big chairman, taking another look at 07 and 08. What you have in front of you is the department's original requests for 07 and 08, and although we certainly have voted out 07, it is now back off the table, and the chairman asked us to take a look at that. Having said that, feel free as members of the committee to ask Carrie anything you want to, but that's what we're doing. But now's the time. Any other points of clarification about that or anything else, please feel free. Just hit your button in front of you, and I'll be glad to recognize you. Go ahead.
All right, thank you, Mr. Chairman. All right, then moving on to 08. Just again, kind of hitting the highlights. And of course, there will be more of them than there was in 07. Starting off on slide 4 of your handout, let's first start talking about the Medicaid and Peach Care for Kids highlights. You have the rest of the Medicaid growth for the benefits in fiscal year 08, funded or recommended for funding of $59 million in state funds. You can find that on page 6, item 17.6.2. There's also a $4 million administrative add for the External Quality Review Organization. This is for Georgia families, the CMOs. We are required by federal regulation to have an external independent entity assess the CMOs to make sure that they're providing quality of care, they have access to care for members, etc. Now you can find that item on page 4, 17.1.10. There's another $35.7 million reflected in the 08 budget related again to the CMO quality assessment fees. Very similar to the item that you saw in fiscal year 07, obviously a different amount. But again, this is an accounting entry to make sure that we're reflecting the amount of revenue we think we will collect from the CMOs and putting it into the correct program. This would be split between Peach Care and between Medicaid. And you can see that there's actually 2 items on page 6. 17.6.1 is the Medicaid piece, and page 7, 17.10.2 is the Peach Care piece. There is a rate increase recommended for the SOURCE program. Again, this is the Medicaid case management program for people who are in our long-term care waiver programs. We're proposing to increase the reimbursement rate from $150 to $175 per member per month. That results in about a $900,000 state fund increase. And you can see that item on page 6, item 17.6.11. And then the last item related to Medicaid and Peach Care for Kids is sort of the annualized rate increase and nursing home provider fee increase that was started in fiscal year 07. It annualizes into 08 at the tune of $21.5 million. Again, the budget is reflecting the collection of these additional fees, and then it is appropriating it back out to pay for a rate increase in the Medicaid program for nursing homes. On slide 5, there's a couple of major highlights related to the state health benefit plan. $176 million in new funding that's actually distributed across other state agencies and through the Department of Education for local boards of education and their contributions to the plan. This is basically accomplished by increasing the percent of payroll that the department assesses for active salaries for both state agencies and local boards of education. Again, that generates about $176 million in new plan revenue, and that's to support the increase that the employer, or that is the state, is to pay for the state health benefit plan. There's an additional $100 million that's been earmarked for OPEB or other post-employment benefits for state employees. Both the item I mentioned as well as OPEB are combined together on page 7, item 17.8.2. That $100 million is really the first in a series of contributions to the retiree health care fund that will go to pay for future costs of employees who are either currently employed and will eventually retire, and their costs will be in the plan. This would help pay for that, or it will pay for current retirees their future costs. There is also an expectation that member premiums will increase by 10% beginning in January of 08. That 10% increase should generate about $30 million in new revenue for the plan. Slide 6 related to healthcare access and improvement. There's two major initiatives in that budget. One is for $1.5 million to support an initiative related to rural healthcare network development, and a second initiative of $1 million to support the Health Information Technology Initiative, including creating a website for transparency of healthcare information to help promote consumerism and citizens of the state making healthcare decisions. And part of that $1 million also includes some funding for some pilot programs to support things like electronic medical records and e-prescribing.
Representative Higley has a question.
Thank you, Mr. Chairman. It appears that the numbers on this slide and the page numbers are a little bit off, so if you'll slow down and let me catch up with you as you go, that would be helpful. But my question has to do with the increase in state employees' premiums by 10%. What is that going to be? What is that dollar amount going to be for the average employee?
I have that. If you'll bear with me, let me give you an exact number. Our most common health plan option that members select is the PPO plan. That plan is available to all members statewide. For members who have single coverage, that amounts to $7.11 per month increase. For members that have family coverage, that would be $21.72 more a month.
How many years will this? How many years consecutively has the premiums increased? So we're at year 2 or 3 or 4 of increase in premiums, so that when my constituents ask me about this, I'll know what we're talking about.
For calendar year 2007, which of course we are in now, for this particular plan year, there was no increase in premiums that members had to pay. In other words, it was frozen at the same amount that they had paid since, I'm going to say either July of 05, I believe, beginning of fiscal year 06. So there was one year that we skip. I think it's reasonable to expect with the cost of the plan going up that it would be likely that members will see some sort of premium increase each year. It's not really the case where you can increase it and then hold it flat, simply because the growth in the plan on the expenditure side has been somewhere between 12 and 14% a year. Members are actually paying it, depending again on the plan they select, but they're paying about 25% of the total cost of the insurance. The state's picking up the other 75%, and as those costs go up, both the state and the member have been expected to chip in that additional incremental amount.
So did costs not go up last year, or we just decided not to pass along any additional costs to employees?
The decision was not to pass along an additional premium increase for members. Instead, the state consumed and covered that cost.
So if we had increased them last year, would they be getting a 10% jump now? Or would it have been a smaller?
Well, given that premium increases are typically decided by, the governor starts it with his recommendation, and it's ultimately agreed to or changed by the General Assembly, that's going to depend. I can tell you that the plan's expenses have been going up anywhere from 12 to 14% a year. So if there's a policy decision that's made that we're going to, both the member and the state are going to equally participate in the increase of those costs, then a 10% premium increase for this year would have been justified no matter what had happened last year.
Thank you.
Representative Gardner.
Thank you, Mr. Chairman. I just wanted to make sure I understand the goal here. The goal is to keep the employee share at about 25%. Is that correct?
That's correct.
And you gave us numbers for the PPO plan. And I guess what I was wondering is if you're in an HMO plan like Kaiser, presumably might be cheaper, is that reflected, or does everybody get 10%?
Everyone will see 10% based on, obviously if they switch a plan, depending on what plan they go to, they may or may not see 10%. But let's say they were in an HMO last year, let's say they were in Kaiser, and next year they're going to select the very same option, then they would see a 10% increase. If they switch to something else, that could be something different because they've made a choice to go to a different plan.
But there's no reward for being in a more efficient plan or less?
That's correct. We've not provided any incentives for members to move to any one plan by changing how much we charge.
Thank you.
It's flat across the board.
Chairman O'Neill.
Thank you, Mr. Chairman. I don't want to interrupt the flow either, and I'm sorry I don't have any background music for my question. I didn't come as prepared as my friend on the right here. I do have great respect for you, though, and that's the reason I asked. And I want you to, if you could, help me understand something. I think every year I understand, and I go home and I don't understand it. And I see the terminology in here again, and it's skipping to a whole other subject matter, the nursing home provider fees.
Yes.
Under Medicaid. It's my understanding that the nursing homes actually pay that.
That's correct.
As some sort of a tax, or we call it a provider fee, and the affect of that is they get it back, and it also ups the federal share in the Medicaid cost. I guess my question's twofold. Is that generally how that works, and then if so, why does the federal government let us get? As almost an old lawyer in another life before I got elected, that almost sounds like conspiracy to me. How can we count on the federal government continuing to do this after we've been through an audit with this sort of a scenario, and are we on safe ground, maybe is what I'm trying to say.
Okay. Well, let me take your first question related to the mechanics, and you're correct. First of all, this is assessed on just about every nursing home bed day in the state. There are some providers who are exempt. We received a waiver from CMS, our federal partner, that we get our federal dollars from, We did receive an approved waiver to exempt some facilities from having to pay the bed fee. Otherwise, every nursing home in the state has to pay that fee. Once those dollars are collected, you are correct, they go back to the nursing homes, but only for the Medicaid beds. Now, in the state, that's probably somewhere around 80% of the beds in the state are paid for by Medicaid, with the rest being paid for by Medicare and private pay. So when we do reimbursement for nursing homes, it's a cost-based reimbursement. Part of the recognition on that cost or in that rate that we pay does consider the fact that a facility has paid a bed tax or has paid that bed fee. So they are getting that reimbursed back to them because the dollars that they are paying in, because it's, as you mentioned, it's like a tax, those look like any other state fund that the department may have appropriated to it for the purposes of drawing down federal dollars. And right now, the bed tax is around $13.11 a day. But just for example's sake, let's say it was $10 a day, because I can do math pretty easily off of $10. The nursing facility pays $10 a day on all of their beds. When we pay their rate back to them, we're going to reflect that they paid $10 a day as part of their Medicaid costs. But when we pay that $10 back, we get federal matching funds. So because it's about a 60-40 split, in other words, 60% comes from the feds, 40% comes from the state. In this case, the 40% is coming from that very pool of money we just collected from the nursing homes. That's able to pull down those federal dollars. So when I pay the facility back the $10 that they've paid, I'm really paying them back in a combination of $6 federal and $4 of the fees that I've just collected. So their net now, I mean, their whole, at least for their Medicaid beds, because they paid me $10 for their bed, I've paid them back $10. But because I was able to use federal dollars to finance part of that payment back, I still have some of their fees left over. It's some of those fees that then are used to do the rate increase in other parts of the reimbursement methodology to recognize that they have higher costs, that they have inflation, that they have capital costs, etc. So you're exactly right. It is financed very heavily from the federal side. As far as your other question about, how long can this last and have we been audited, first of all, we have to receive approval from CMS in order to do this. They recognize and they know that we have a provider fee. And they approve to make sure that we are complying with federal regs that are very prescriptive about how that program has to be operated. A couple things we have to demonstrate to them. One, we have to demonstrate that we've not held any provider, what we call them, we've not held anybody harmless from paying the tax. And there's a certain formula in the reg that we have to statistically calculate that proves that. We also have to apply the tax uniformly. So again, we can't make some providers pay more and some providers pay less. They all have to pay the same amount per bed.
Can I stop you right there where, don't forget, if we hold somebody harmless, how is that different from the waiver that you said that you say we can't hold them harmless, yet you say we have given waivers to some nursing homes, which means you don't have to pay this, right?
That's correct. But they also don't get in their rate, there's no recognition that they've paid a tax either. So in other words, I don't pay them $10 because they haven't paid me $10. When I do the hold harmless calculation, I have to consider all of the facilities in the state. It doesn't have to be on a provider-by-provider basis. I have to look at it from a total perspective of the aggregate. The waiver, we actually waive about, I believe it's 3 different types of providers. One are the top 10 Medicaid providers by bed day. 2 are continuing care retirement centers, and there's probably about 5 or 6 of them in the state. And then we also can exempt charitable nursing homes, which there is 1 in the state. So we have about 16 or 17 providers that are exempt. Everybody else is paying. Providers that have low Medicaid utilization, they are definitely not held harmless. In other words, they're spending they're paying in a tax, but they're not necessarily getting it all back because they have a low Medicaid percentage. So that's how you demonstrate that you're not holding anybody harmless, is that everybody's uniformly paying. When you consider, again, that formula, that statistical formula, the facilities that are a part of the waived facilities are calculated in that. And so, again, what CMS is looking for is that the group as the whole is not being held harmless. What they don't want to see is we collect a fee, we pull down federal funds, and send the same exact amount right back without the state really putting up any money. And so that's what we have to demonstrate. CMS is looking at this area. In fact, they have just issued a proposed rule I think it was last week, and they are beginning to, I'd say, downsize this program. Right now, we can tax up to 6% of a provider class, which nursing homes are a provider class. We can tax up to 6% of their revenue. Beginning in January of 2008, that will be reduced down to 5.5%, and by 2011, they want to reduce it down to 3%. So the amount that we can tax, match federal dollars, and pay back is slowly being reduced. Anytime we do any sort of change to the reimbursement rates for nursing homes, CMS takes a look at all of our calculations. In fact, this provider fee increase that we just did, that's part of the 07 budget, we just received CMS approval, but it was only after we demonstrated that we hadn't violated the hold harmless provision, and that we went back and showed them exactly how we were collecting the money and how it was going back out. So, for now, we're doing everything by the book. We really can't do anything without CMS agreeing to it because they're putting up 60% of the money. But I would say that, this is an area they're definitely looking at, and they're already demonstrating that they will be scaling it down what states can do in the next several years.
Thank you. Thank you.
Representative Gardner. Karen, let me revisit one thing I thought I heard you say. Did you, the state health benefit plan, did you say that that's been increasing 12 to 14% a year in recent years?
Total expenditures, yes, have been growing by that.
Do you have, in contrast to Medicaid, what part of that increase has been enrollment increases and utilization and medical inflation versus, say, Medicaid? Can you contrast that with Medicaid growth over the same period of time in those same areas?
At least for what we project going forward, I really would have to go back and give you the actual statistics for 06 for both programs. But at least going forward, I can tell you that we're projecting a 12% increase in expenditures in fiscal year 08 as compared to 07. Probably around 2 to 2.5% of that increase is related to enrollment growth in the plan. The rest of it we attribute to a per member per month increase, which would be a combination of utilization growth and medical inflation. So the other, basically 9.5 to 10% is that medical inflation utilization piece of it, and really a pretty small amount is enrollment.
Would you contrast that with Medicaid?
Medicaid, we're down somewhere as far as total growth in somewhere between 5.5 to 6%. Most of that is, I would say, probably 3 to 4% of Medicaid is related to that per member per month growth and utilization change and inflation growth. Of course, some of that is tempered by us moving a significant amount of our members into the CMOs, which means we negotiate what that inflation is going to be each year, as well as on the age blind and disabled side. We've implemented a lot of administrative service organization functions that are designed at the management of the benefit, which have kept that per member per month growth down. And then probably, I want to say, The remainder of the 5.5% to 6% growth is on the enrollment side, although we have seen flattening enrollment in the age blind disabled program, and we have seen sort of a temporary decline in the low-income Medicaid program in calendar year 06, primarily due to the requirements that members show proof of income and proof of citizenship. But I would expect that to be a one-time sort of reduction to the base enrollment, and that enrollment will normalize probably in this calendar year and going forward. And what I mean by that is saying that it will be closely linked to the economy as well as just enrollment growth or population growth in the state.
But would it be accurate to say that over the last few years, state health benefit plan has been growing percentage-wise? The cost has been growing percentage-wise greater than Medicaid?
I think that's true. The only exception I would say is when we converted to the new PPO in calendar year 2006 and did a variety of other reforms, we were able to bring total expenditures down. I kind of see that as sort of a one-time flattening of the growth, but that we're still seeing those trends going forward. So yes, I would say that we've been able to control per member per month growth in Medicaid a little easier than we have been in the state health benefit plan.
Representative Gardner.
Mr. Chairman, I'm thinking about the income and citizenship verification procedures that you put in place, and it seems to me that I saw somewhere that when you put these in place for Medicaid, there was a drop in enrollment of about 60,000 children. Did I remember that correctly?
I think you're referring to some statistics we released to the Atlanta Journal that I think the drop was around 69,000 children during a certain period of time.
And did you also tell us that you intend to institute those same income verification and citizenship verification procedures for Peach Care in the near future?
We already have income verification procedures in Peach Care, but we're basically doing it on a limited basis. In other words, not every single member is subject to that.
Oh.
And what we will be doing in the very near future is expanding that to all members.
So that as of what date will the income and citizenship verification be automatic in Peach Care? Do you know?
Right. Do you know when they're? In July 1st.
So as of July 1st, you'll have in place the procedures to
do
check
100%.
100% income and citizenship, correct?
Right now we're doing a Department of Labor database match, which nets somewhere between 20 and 30% a month of matches, and then the rest is a random sample of about 10% of the members. So we'll go from probably around 30 to 40% validation up to 100% in July.
And do you have any projections about the number of recipients that might not be eligible?
Preliminarily, and based on, again, the sample that we do now, we think it may be around 3%.
Around 3%?
3% that we've been covering that would not be able to validate the income that they have reported.
Thank you.
Representative Hughley.
Thank you, Mr. Chairman. If you don't mind, I'd like to go back to your explanation that you gave to Representative O'Neill about the nursing home funding arrangement. It sounds similar to some funding arrangement that we had with hospitals in the past. And so my question is, what are we doing now that we know that this arrangement has a limited time frame? What are we doing and working with our nursing homes in preparation for the decreases that you anticipate will be coming from the federal government?
Well, I think the only thing we've done so far is acknowledge that they're coming. I've had some conversations with the Georgia Healthcare Association, which was formerly the Nursing Home Association, and we have talked about it. As far as how we will handle it, I don't think that's been decided. I think there's some options. One, we can reduce rates, that have, previously the dollars that have financed rates, we can reduce rates in order to balance back to what available revenue there will be. The other alternative is supplementing the loss of those provider fee revenues with state appropriations to maintain reimbursement. And those are pretty much the two options. Obviously those two things we've got to work with the General Assembly to figure out which one that's going to be. That's not something we can do on our own.
But can we anticipate that the department will come forward with a recommendation before we're in a crunch and the nursing homes are ringing all our phones about this funding mechanism no longer available to them, because we know what happened to the hospitals, and so it appears that the federal government allows these funding mechanisms for a specific time period and then they change their minds.
Well, my understanding in speaking with the president of the association, that his members are aware that this is coming. Obviously that doesn't address, well, then what happens. They know it's coming, but past that, how that will be handled and whether they will see a reduction or whether the state will come in with additional dollars remains to be determined.
Thank you.
Okay. All right. Let's see, how far did I get? I think I got to slide 6, the healthcare access and improvement. The third bullet under that, there are reductions of 2007 one-time funding. There's about 3 items that were funded in fiscal year 07 that the governor's recommendation has removed from the 08 base, and those total up to about $1.1 million. You can see them on page 5, items 17.3.6 through 17.3.9. Oh, excuse me, 6 and 7, and then item 9 under 17.3 section. The last 2 items relate to something that impacts the department as a whole. You see $387,000 in new state funds related to agency administrative support. Most of those dollars are related to the annualizer and the new positions that were funded in fiscal year 2007. There are some additional FTEs that were newly funded in 2008, including some positions for program integrity and 1 position for financial management, which would be an actuarial position. And then finally, no dollar impact as far as a cut or add to the department's budget, but certainly a pretty significant shift in the way the department's programmatic budget is structured. Basically, the proposal is to consolidate several existing programs into one big program called Medicaid, and then to have sub-programs that would allow to still, for both the governor and the General Assembly, to see the components of that big, large program broken down into the sub-program level, but by consolidating all into one big program allows the department more flexibility to ensure that we have money available to pay our providers. And those particular line items are scattered throughout the document. Probably the one that reflects, at least the creation of the big Medicaid program is on page 6, item 17.6.1.
Carrie, just a matter of information for the committee, have you had any feedback from the Senate on that approach?
Yes, they don't like it.
Thank you.
Well, I mean, that's true, they don't.
I was just checking.
Okay.
Representative Parrish has a question.
Mr. Chairman, I want to ask a question, and it's sort of in general. I'm not sure if you need to answer this, or maybe you and Kerry. Could you give us sort of the latest update, as y'all understand it, about what may be happening in the Peach Care funding as far as Washington is concerned, where we are with that?
Representative Parrish, I'll tell you what I think I know, and that is that in the current version, budget version of the Iraqi war funding in the House, that money has been approved, and that has passed the House, I think it's fairly clear that that version is going to be vetoed by President Bush. He's made it clear that he is. And so when that happens, then they'll go back to the drawing board, and my understanding is that the reason he is given for his upcoming veto is the timetable as it relates to the war. I don't know about the funding, but my understanding of what happens when he vetoes it, they go back to the drawing board and present him with another bill. So apparently on both the House and the Senate side, as I can tell, there's support for the $745 million. It's a question of how it works its way through the process in Washington. I don't know if you have further
No, sir, I don't have anything
information
additional
on
to
that.
add. All right, those were the highlights. Just giving you sort of the numbers summary. 5.4% increase in the state funds budget, most of which is related to the partial growth of the Medicaid benefits growth for 08, as well as the provider fees that are being accounted for from both the nursing homes and the CMOs. Total new state funds for the department is $123.9 million. And then, of course, there's about $276 million that will flow through the state health benefit plan. Again, those dollars are not appropriated directly to DCH. They're being appropriated to all of the other agencies as well as DOE for them to distribute down to the local boards of education. But it does come back to the plan as other revenue through our percent of payroll collections. So state funds budget in 08 would be about $2.5 billion, again about $124 million higher than the base. Mr. Chairman, those are the highlights, and if there are specifics you'd like to go back over in the tracking sheets, I'm certainly happy to do that, or try to answer other questions.
Representative Gardner.
On that last sheet, you have the Peach Care for Kids, $14.2 million, reduces CMO administration rates and show changes to CMO fees.
Yes, ma'am.
Explain that a little bit, please.
Yes, there's really two parts to this. One is the quality assessment fees, again, the provider fee that we're assessing to CMOs. Part of it is reflecting that we will earn money related to the revenue that the CMOs receive from Peach Care children being assigned to them. So they are assessed up to the 6%, and those dollars would be used to as a state matching fund source for Peach Care expenditures. That's offset by about an $8 million transfer from Peach Care to Medicaid. The idea being that in the capitation rates that we pay CMOs, of course, part of that rate includes administrative costs that the CMOs have to run their plans. Pretty much you can break down their costs between fixed costs that they're going to have no matter how many people they serve, and then variable cost, which is directly related to enrollment. What we want to do for fiscal year 2008 is when we negotiate capitation payments for both Medicaid and Peach Care, we have asked the CMOs when they are proposing their rates to us and we are negotiating with them, is that any variable costs be removed from the Peach Care cap rate and moved over to the Medicaid rate. So you'll see a reduction in Peach Care and an add in Medicaid. It's a wash as far as the department is concerned from the department level budget. But what that should do is to reduce expenditures on the Peach Care side, which should help with the federal fund problem.
So that doesn't include your renegotiations with the CMO?
It does not. It does not. That's only one piece of it.
When would that occur?
It's occurring now. We have to have rates decided no later than May 1st so that we can give them to CMS for their approval and to have them loaded and ready to go in the system for July 1.
And you're assuming that the fees will be lower?
Well, we would like the fees to be lower. We will require them to move that variable administrative cost over to the Medicaid side so we can achieve that $8.2, I think it is, $million savings. But we would certainly like to see above and beyond that a reduction in what we're spending on Peach Care, which is not a part of the budget document at this time.
So you haven't projected what the reduction would be?
No.
Chairman O'Neill.
Thank you, Mr. Chairman. Again, skipping to another subject. It's only because I have so much respect for you that I keep asking these hard-to-answer questions. I guess maybe they are. I hear more and more every day about a fairly significant policy change in the way we're dealing with mental health care in the state, where we had gone from a prior system of grant and aid, and the new philosophy is to get back to an indemnification or a reimbursement system, which i.e. means Medicaid. I don't see any dollars of additional burden or obligation on your agency if we do shift from grant and aid, which has been coming from DHR all this time. If that's not going to be paid by them, do you, if it's now going to have to be absorbed by Medicaid, are all of those numbers in your 08 budget numbers? And are you satisfied that you all are going to be funded adequately to handle this new Medicaid reimbursement system of mental health care that heretofore was done an entirely different way outside your budget parameters?
Representative O'Neill, as I understand it, it is not Medicaid that will be responsible for paying this new way that you're referring to. As I understand it, it will mirror the way Medicaid handles reimbursement. That is, on a fee-for-service basis, the provider provides a service, they send in a claim, the claim is adjudicated and theoretically paid, and the funding comes back to the provider. As I understand what DHR is moving towards is a comparable system, but not necessarily with Medicaid funds, but with state appropriation and other federal block grant monies that they have available to them today for mental health services that are provided to people outside of the Medicaid program. So they will have a claim system, but it will not be funded with Medicaid dollars as far as I'm aware. So that's why you don't really see anything in our budget, because it's not really coming through Medicaid. Medicaid is not providing any dollars for that change in the way they logistically pay for mental health services out around the state.
Thank you.
Representative Gardner.
This is a follow-up from that. So you're anticipating that there will be a block grant from the federal fund or the state budget that will pick up the psychosocial services that are not reimbursed through the fee-for-service program?
That's correct. And I want to be clear that what Medicaid is already paying for and the people who are Medicaid eligible, that's, at this point, we are not anticipating that to change. And we're really not talking about anything that's different about the delivery of those services. This is for people who are not Medicaid eligible or for services that Medicaid does not cover. My understanding is DHR will be, instead of giving, let's say, a community service board, here's your annual grant and aid or whatever you want to call it for, this bundle of services, they now have to bill, just like they are already billing for Medicaid, they're now going to have to bill DHR's fiscal agent for the claim for the service actually provided. So, and I'm assuming that DHR will continue to use whatever fund sources they've been previously using to fund these grants. These grants or the dollars that are going out, that will continue to be the fund source, except now they'll be using it on a fee-for-service versus like an upfront. Here's your dollars.
I can just follow up, Mr. Chairman. One of my concerns is that under the CMO program or the fee-for-service program, the services that are provided are the medically necessary services, and the typical psychosocial services that have previously been covered one way or another, sometimes by Medicaid and sometimes not, that the people who need those psychosocial services will not be able to get them, and then I suspect that the funding crunch will occur probably in the county jail or the Department of Corrections. So I'm concerned about the gap that could occur as a result of this so much change to fee-for-service at the same time the CMOs are deciding to pay only for medically necessary services. I guess that's for another
It would
day.
seem that certainly there have been changes to providers who serve Medicaid patients because of the advent of the CMOs, but that's, as I understand it, separate and apart from what DHR is doing for other fund sources that they have available to pay for services outside of the Medicaid world, if you will. I kind of feel like I know enough about this to be dangerous, and
Me
really
too.
we should have DHR to come in and talk to you about what their plans are.
I'm worried about the gap of those set of services that both the CMOs and the fee-for-service system doesn't adequately cover.
Yes, ma'am.
It's not a question, it's a comment.
Carrie, on the 08 budget, on our tracking sheet, page 5, item 17.3.8, back of settlement fund to increase access to primary health care in rural Georgia, $1.5 million. Can you go over that with us one more time? I mean, exactly how are you proposing to use these funds, and what are you going to accomplish?
Mr. Chairman, as I understand, and this is an initiative through our Office of Rural Health in Cordele, they have, of course, work every day with rural providers, and I think one of the things that they see is a gap, in some cases, between the local primary care level providers and more regional medical providers that are primarily hospitals or other tertiary centers, and making that connectivity. So as I understand what they want to do with these dollars, these are planning and development dollars. I think as we've discussed before, that this is really the first of a several-year initiative that would provide through competitive procurement, and when I say competitive procurement, I mean rural health groups would come forward with proposals on how they would take these dollars, pieces of these dollars. Obviously, it wouldn't necessarily go to all one group of people or providers. In fact, we would hope that it would cover somewhere between 3 and 5 different separate proposals, but that they would take those dollars and that they would use it for planning and development on how they would strengthen the safety net in their particular region of the state. Brian, do we have a we have a total for the whole the whole? This is the phase, the planning piece, which is $1.5 million. It's over 5 years, and do we have a total? I apologize, Mr. Chairman, we don't have a total, but we do. We can get you that, but the idea is this is really step one of a multi-year approach to addressing this issue.
Again, I'll follow if I can. So this money is to be used for planning and development, and they're going to be, there's a pot of money to be used for that purpose. Is that correct?
Correct, but with an assumption that as we're awarding, to those entities that receive that planning and development money, that obviously, as a result of that planning and development, there will be future activities that will require additional funding. That's actually more of the operational part of the phase.
Yeah, and that's going to be competitive among. You mentioned 3 to 5 proposals. I mean,
I think that's their goal is to award 3 to 5 awards. How many people will apply? I don't know that we know that, but.
So if it were 3 awards, that'd be $500,000 apiece or something like that to somebody.
Yes, could be.
And it's for, again, help me understand what it's for. I'm planning what?
Are you familiar with the Georgia Cancer Coalition and their regional programs of excellence?
Yes, ma'am.
And you know that they started out with a coalition of people who were all, I mean, this is the best analogy that I can give you. The folks that were all had the goal of, I don't say treating, but being somewhere in the continuum of care for cancer. Either they were at the detection level, they were at the research level, they were at the treatment level. And all of these little groups that were all out there providing a piece of the whole puzzle as it related to cancer. And one of the major goals of the Cancer Regional Programs of Excellence was to bring that all together and have that to be coordinated and consolidated. I think, as I understand it, it's similar. That approach is similar here, is where you have disparate groups that are out there providing, you know, a piece of primary care for in rural areas, and not just primary care, but I mean that could be one component. It could be providing emergent care. They could be providing surgical care. I mean, really, the whole spectrum of healthcare delivery out in the rural community. I think the idea is it's somewhat fragmented, and the idea is to bring it all together through this planning effort. So, how do these people work together better so that it's more streamlined? There's not duplication of effort. It fills in where there may be holes in that spectrum or that continuum, etc.
Well, again, groups like what? I mean, could you give me like a example of who might win a grant?
It could be a hospital system. Good example is the Archibald Hospital System down in southwest Georgia. They have small hospitals that are like critical access hospitals that have relationships with the main hospital in Thomasville. So, a group like that may be missing partnership with, say, a rural health center. That's like a community health center that's providing primary care that may then feed into the smaller hospital for more emergent care or more outpatient services, versus at some point somebody may need the care of the Thomasville campus, which is I forgot what level trauma center they are, but that can provide a more comprehensive set of services, including surgery services, etc.
I think it's fair to say we all for increasing access to primary health care in rural Georgia, but I know the chair's had a number of questions about that, and I don't know if I still got my arms around what we're doing here exactly, but maybe we can come back to that. Representative Gardner.
Thank you, Mr. Chairman. On page 4 of 8, 1717, we had a discussion previously about the software program. Correct. And I've had several. Why don't you tell me exactly what that's going to be used for, how the department's going to be used that, and I guess the question was how it was going to be integrated into your next vendor in the case that you decide to replace ACS.
Right, excuse me, Representative Gardner, what item was that?
1717.
On 08 or 07?
08.
17-1 what? 7?
On page 4 was the front page of 08.
Okay, I'm sorry. Go ahead.
Okay, thank you. Representative Garner, after our last discussion about this, I did follow up with Doug Colburn, who's our Inspector General, who gave me some, I think, hopefully the answers to some of the questions that you had. First of all, as it relates to the new MMIS, he says that he refers to this as pre-claim filtering, and I think we talked about this before. Mm-hmm. He said this is not built into the MMIS. So in other words, he's saying this would be above and beyond or in addition to what the new MMIS would do. So in other words, it would not be, we wouldn't be paying for the software for a couple years and then it being obsolete because the new MMIS is going to handle it. So
it will be continually used.
It will continue on, and it would interact or interface with the new MMIS, but it would not be a part of the new MMIS. So that's one, I think, answer to the question. As far as how it is going to work, he says that claims that are identified as suspect would suspend until released. But he did point out that the software would have a timeout, what he calls a timeout capability. It basically says unless we work the suspended claims within a certain amount of time, they would go ahead and be released in what we would call like a pay and report. We've paid it. There was some question about it, but we didn't have a chance to work it before some reasonable amount of time passed, and so went ahead and paid out. He gave us an example of the kind of thing it would pick up, and he says upcoding is one example. He says office visits billed for a more intensive time frame that actually occurred. The software would detect if a high rate of intensive visits were billed and suspend the claims after a certain threshold was reached. The system would simultaneously notify an analyst at the department, which these analysts are the part of the package that's being asked for, as would notify the analyst so a human could actually look into the issue. So the software is just going to sort of pop up the red flags, and then the positions that come with this package would actually be the ones working those suspended claims. And then, if I may also, I know Representative Parrish, you had a question about pharmacy claims in particular. As he says, pharmacy claims would be subject to screening for adjudication patterns. However, it would not prevent point-of-sale claims. Instead, claim patterns would be developed. It's just more of an after-the-fact kind of look. I think Representative Stevens had a similar question about that.
Can I have one more question, Mr. Chairman? I mean, I had a meeting with the DeKalb CSB and APS, which is the utilization management for mental health claims. Is this going to apply to both Peach Care and Medicaid clients who are in the ABD population as well as the regular Medicaid and Peach Care population?
This would apply only to members who are in our fee-for-service world. Obviously, the CMOs are going to have their own, fraud detection or, claim pre-filtering software that would not, this wouldn't impact.
So this doesn't impact on the CMOs at all?
Correct. This is only going to be ABD claims. Anything that's coming into the department that we're paying on a fee-for-service basis. And I think in relation to the question about, like for CSBs who are already having to go through APS, I would not imagine that this would also pick those up since they've been they've been separately reviewed and evaluated for appropriateness through the PA process.
Well, the DeKalb CSB, for example, has its pre-screening process, and then it goes through the APS screening process. Would this come before or after all of that?
Well, it will come as the claims are coming into the system, but before they're adjudicated by the MMIS.
So it would become
apparently would be after.
After the CSB has submitted the claim, but before APS has evaluated it.
No, I think APS, in order for them to, as I understand the way that works, APS is giving a prior authorization for services above a certain level. That authorization has to be in the system for that claim to adjudicate. So that will still be in there. I think, and again, I'm not sure that this pre-filter is going to apply to any kind of claims that have been subject to a PA. Seems to me that would be duplicative.
It seems duplicative. That's why I was asking the question. Thank you.
I can follow up with Mr. Colburn and have him validate that. Because it's not just mental health. I mean, there's obviously other claims that are subject to PA that may make no sense to have those subject to a filter as well.
How many utilization management contracts do you have in addition to APS?
Utilization, we have one with Georgia Medical Care Foundation that does, does many things, but does, for example, prior authorization of inpatient hospital admissions. It also does some work for the Katie Beckett waiver population as far as medical necessity related to the eligibility. That's not really claim, it's more member specific. Certainly we have other vendors who do case management, which isn't necessarily the same as utilization control.
Thank you, Mr. Chairman.
Thank you. I want to go back to a previous question where I asked about the increase in the state employees plan, and you said that increase is between 12% to 14% per year. And then there was another question about Medicaid, and you said that increases like 4 to 5% a year?
5 to 6, yes, ma'am.
So why would we make a policy decision to make Peach Care look more like state health benefit plan?
Well, as
In
I
terms
understand-
of costs and saving monies and that kind of thing.
Well, as I understand the discussion about making Peach Care look like state health benefit plan, it's been more in terms of the scope of services covered. And that scope for children, of course, state health benefit plan does not cover dental, primary dental care, and it does not cover vision, primary vision care. State employees who want that benefit have to buy into that program separately through the merit system.
But wouldn't the reason for that be the cost already associated with that plan and the fact that people in state health benefit plan have more options than do persons in Peach Care?
Well, it really is an apples and oranges comparison. If you look at what the cost drivers are in the health benefit plan as compared to what they are in Peach Care, Peach Care, the cost driver is enrollment. Really, the per member per month cost in Peach Care has not significantly fluctuated any more than probably typical medical inflation. And in other words, I don't think we're getting a sicker group of children. We're just getting a whole lot more kids than we ever had before. On the health benefit side, we really have pretty low enrollment growth of only maybe 2 to 3% a year, but the demographics of the members in the health benefit plan and those that are the most expensive to the plan are those who are pre-65 retirees. These are members who are probably anywhere from age 55 to 65 who have retired, who are, certainly at that point in life, there's, you have a lot of screenings that are recommended that have a cost. Certainly people have illness at that point in time. I mean, it's a whole different population where the kids in Peach Care are pretty basically healthy children. They just need coverage. People in the state health benefit plan, particularly those that we see as the most expensive to the plan, are those that have acute conditions that end up being very expensive.
So, for example, you're saying that under state health benefit plan, you're paying for colonoscomies when people get to be a certain age, mammograms, services that children would not need to maintain their health status. So you're saying to me that it's an apples and oranges comparison because it's a different demographic, and any comparison between those two are going to necessarily be flawed?
I think so. Certainly we cover children in state health benefit plan. I would really need to isolate just their expenditures to compare them to Peach Care to get more of an apples and apples comparison. It's not just, and I don't want you to think that the health benefit plan doesn't want to invest in things like screenings, because if we can catch something that's going to save dollars down the line, we understand the importance of investing in those kind of preventative procedures. But it's not only that they're getting the screenings for mammogram, colonoscopies, etc., but they're also getting breast cancer, colon cancer, they're having heart attacks. There's just things that happen as you get older that the plan is paying for. Really when people get to age 65 and Medicare comes in as a primary care coverage, the plan converts to a supplemental payer and our expense is much less. But it's that sort of peak period that those people look a whole lot different than Peach Care.
Can you get for me the age ranges that we're talking about for state health benefit plan? We know in Peach Care we're talking about 0 to 18. State health benefit plan, you're talking about a wider range of ages and conditions that would necessarily you'd have to look out for.
We have about 160,000 children in the health benefit plan that are covered. We have a total, I think our last enrollment count for the health plan was somewhere around 670,000 covered lives. And so 160,000 of those are for kids that are 18 and under. The rest, we can give you the demographics of, what sort of normal age stratifications,
Please.
All the way up to over 65. That's no problem to do.
Thank you. Thank you, Mr. Chairman.
You're welcome. As a follow-up to Representative Hughley's question, there those 160,000 kids in the state health benefit plan. Do you all have a breakout as to what the per child per month expenditure is for them versus, say, Peach Care?
We do. I don't have it with me. I mean, I can't quote it to you offhand, but yeah, we should be able to get that.
From your memory, is that higher or lower?
I'd hate to speculate.
If you don't mind, that would be of interest to the committee.
Sure.
On page, I'm talking from the 08 document now, page 4 of 8, item 1735. I guess same kind of questions that I was asking about increasing access to primary health care. Could you shed some light on, a little bit more light on that health information technology pilot, $1 million? Would you tell us again how that's going to be used and so forth?
And before I do that, Mr. Chairman, may I recommend on the other initiative, on the Rural Health Safety Net initiative, if you are so inclined, I would really like to get Charles Owens, the director of the Office of Rural Health, to come and either testify before the committee or provide some other comments to you. I feel like I've done not a disservice, but I want him, because he's, this is going through his office, and I'd like him to have the opportunity to further explain so you have a comfort level about this particular item.
Yes, ma'am. I think that would be very helpful. Thank you.
Okay. I'll make sure that we get that scheduled, and I'll ask Margie to help on that. On the HITT, this is the $1 million. And I think you've heard the commissioner talk about this initiative rather passionately. She is 100% for this, and I think is looking forward to hopefully your agreement by appropriating these dollars. Pretty much it's broken up into two components. One is related to a website, what we call a transparency website, and the estimated need on that is about $400,000 out of the $1 million. And I'm reading here so I get this straight, but basically this money is needed to procure the work or the resources needed for the web-based consumer information site. The cost would include development or a customization of an existing platform that may already be in use elsewhere, and that's obviously being determined. The content development, and then using consumer focus groups to help hone what that website is going to look like and what's going to be user-friendly. That $400,000 would also include funding for a project manager to oversee the development of that website and to get it up and running. On the Health Information Exchange, which is the second piece of the initiative, the idea is to fund pilot programs, possibly up to $200,000 per pilot, which would allow us to do 3 pilots with the remaining $600,000. There would be a requirement that there were matching funds that the entities would have to put up. The things that we would be looking for are people who are interested in doing things with electronic health records and e-prescribing. All of these particular proposals would be evaluated by the department's Health Information Technology and Transparency Advisory Committee that's not a committee, excuse me, it's a council that the governor recently appointed earlier in the calendar year. They would be the one to determine the criteria that would evaluate the proposals and to ultimately make the decision about which entities would receive these dollars.
Representative Sheldon.
Yes, I have a question about the cost. Do you know what, I know this would be in for the 08, but what will be the cost for the website as it carries forward to maintain the website?
Well, right now there's $400,000 out of the $1 million earmarked, since a lot of that would be development, one-time development. think it'd be hard to say. Certainly, I wouldn't think it would be quite the 400,000. I don't know if we have a annualizer in the 08 budget, or that, well, it would be 09 and on. Do you have any idea? I'm sorry, all you can tell you is no more than the 400,000 that they've earmarked. But again, it would make sense that if that's going to include development, the ongoing cost would be less.
Okay, thank you.
Again, on the pilot, how many folk, I mean, where's the pilot going to be exactly?
Well, there's not been a determination on, like, you mean geographically where?
Yes, ma'am.
No, there's not. That's not been decided. That, again, is supposed to be a competitive application, and that the HITT Council will be deciding. So to be determined once the dollars are available.
To be determined. Representative Shelton.
Yes, I have one more question about the website. Are the rules and regs in place to do this website, or do we need to do legislation to ensure that for the transparency?
There is a companion, well, there's legislation that the department is proposing, I think, as you know, that would allow us to collect the data necessary to put in the website.
Okay.
So first step would be getting that legislation passed, and then I honestly can't tell you right here whether or not there would be rules and regs after that, possibly so, but the idea would be to have this ready and up and ready for July 1. So I think certainly we could accommodate that between now and July.
So in order for us to ensure that transparency is available to consumers, we need to act legislatively?
Yes.
Okay.
Yes, ma'am.
Thank you.
Any further questions from the committee? If not, thank you very much, Gab. We stand adjourned.
Okay. Thank you very much.